so when making a clinical decision to place a central line, I'm gonna go over the indications, volume resuscitation, the anticipated need for vasoactive infusions, and then if we anticipate the need to transduce for CVP monitoring. So I'm gonna go meet the patient pre-op, go over the risk and benefits of the placement, and obtain informed consent. While I'm out there, I'm going to assess potential sites for insertion. Right IJ is preferable. It's more direct access to the atrium. The left side is a less direct, takes a turn, and there's also anatomical structures on the left side, like the thoracic duct, which could produce some complications. So I'm gonna go for the right side. I'm gonna assess for any signs of infection on the skin, any warmth, redness, drainage, anything, pain. His right side looks okay, so we're gonna do the right IJ today. So I'm gonna bring him back to the OR like normal, get some monitors hooked up, make sure I have my resuscitation equipment available, make sure I have my ultrasound in the room on and everything set up, and obtain any necessary supplies that might not be in my kit. So after reading what's in my kit, I know that I'm gonna need a Tegaderm for dressing it and a BioPatch. So I've got those ready. Go ahead and induce the patient because I'm gonna place the line after induction. I'm going to position the patient for optimal access and visualization, put them in slight Trendelenburg for venous engorgement, turn their head away from the insertion site and maybe take their pillow out to make access easier for me. Following that, I'm going to identify my external landmarks for where I'm gonna go. So I have my sternal head of my sternocleidomastoid muscle, my clavicular head, my clavicle right here, and cricoid cartilage right here, and ipsilateral nipple. That's the direction I'm going to be aiming in. So I feel confident. I'm going to feel for my carotid pulse. I know the IJ is going to be just lateral to that. So I'm going to go ahead and open my kit, prep the site. I'm going to core prep here. Prep the site. Going in a triangle, I'm going to start up here at the top of the sternocleidomastoid muscle, go down to the sternum, across the ipsilateral nipple, and back up. Clean that really well for a couple of minutes. Let it air dry. While that's drying, I'm going to open my kit up the rest of the way, maintaining sterility. All right, next I'm going to don my gown and gloves. Go ahead and open up my gloves. I have a coworker come and fasten my gown. Gloves, cuff to cuff, thumb to thumb. I'm going to apply the sterile drape to the patient. Head pointing towards the head. Open the drape towards me first. Go ahead and re-identify my landmarks with the drape applied. Still got my sternal head of the sternocleidomastoid, the clavicular head. I can feel my clavicle down here, cricoid cartilage. I can still palpate my carotid pulse. So I think I'm in a good position. I'm going to get my kit together. Got my guide wire. my scalpel, which I'll go ahead and uncap. My dilator is ready. I'm gonna assess my catheter, make sure the tip is intact, make sure the distal port is open. The other two are clamped. I've got my needle. I'm gonna uncap this so it's ready to use. Some syringes, I think we're good. Okay. Now I'm gonna have my coworker drop my sterile probe cover into my sterile field. Thank you. Apply some sterile gel. Thank you. All right, I'm gonna have my coworker hand me the probe, maintaining sterility. Thank you. I'm going to make sure that this sheath travels all the way down the cord. I'm going to apply rubber bands right here and at the bottom of the probe. Go ahead and apply some more sterile gel, thank you. And I'm going to go ahead and take a look, identify some internal landmarks with my probe. Go ahead and make sure I have my probe correctly oriented. Okay, so I see, look for the carotid pulse to be carotid artery to be pulsating, which I do see. I see the IJ right lateral to it, and it's compressible. Okay, I do not see pulsation in the IJ. I'm gonna get it right in the middle of my screen. Okay. Using my needle, bevel up, I'm gonna aim towards the ipsilateral nipple at a 45-degree angle, aspirating as I insert, and watching for it on the ultrasound, entering the vein. I see it there, and I get blood return. That is dark red. I'm gonna drop my angle, aspirate again, still get blood return, still dark red. Advance my catheter without advancing my needle. Remove my needle. Again, still dark red blood, not pulsating, so I feel confident that I am venous. I'm gonna go ahead and use my guide wire. Inserting it 12 to 15 centimeters. Go ahead and withdraw my catheter from around my guide wire. As I'm inserting the guide wire, I'd be looking for any arrhythmias on the monitor. Now with my guide wire in place, I'm going to take another look with my ultrasound probe, verifying placement in the vein still. Going in plane view, and I can see it there, so I know I'm still venous. Perfect. I'm going to perform a skin nick with the blade away, pointed away from the guide wire. Okay. I'm going to use my dilator to ease access for the central catheter. Feeling for the pop of the platysma. Okay. And I'm going to thread my catheter. Watching for it to exit the distal port as I advance. All right, I see it now. Go ahead and grab onto this and do a push-pull with the guide wire and the catheter. Inserting the catheter into the vein. Okay, remove my guide wire the rest of the way out. I'm going to check aspirate for blood return in all of my ports and subsequently flush them. Okay. All right. Go ahead and suture the line in place, apply my BioPatch, my Tegaderm, and go ahead and transduce the distal port for CVP monitoring, assess my waveform, proper waveform morphology for a CVP monitor, and proceed with the surgical procedure.